Welcome back, everyone, to part 24 of our internal medicine review questions. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you very much who have already donated. All right, let's start out with question one. A 37-year-old, oh, by the way, we're going to have three in a row here. So you're going to lock in your answer here. We'll move on to the next one and then the one following that, and then we'll discuss this patient. A 37-year-old woman presents to the clinic complaining of worsening hand and wrist pain for the past 2 months. She says that the pain is worse when she wakes up in the morning and improves gradually throughout the day. She also describes general fatigue. She denies rash and fever. She sleeps 7 to 8 hours every night and does not nap during the day, but says she feels sluggish. No significant past medical history. She's on a prenatal vitamin. Family history is significant for Crohn's disease and her sister, who's 33. She works as a kindergarten teacher. She does not drink alcohol, smoke, or use recreational drugs. Vitals are within normal limits. Physical exam reveals warmth, swelling, and tenderness of the 2nd through 5th proximal interphalangeal joints, metacarpophalangeal joints, and the wrists bilaterally. Which of the following is the best next step in the management of this patient? A, obtain rheumatoid factor and start naproxen. B, obtain Borrelia serology and start doxycycline. C, obtain parvovirus B19 antibody titers and start acetaminophen. D, obtain anti-dsDNA antibody titers and start naproxen. Or E, obtain anti-CCP antibody titers and start sulfasalazine. Okay, I'm going to move on to the next question here. 10 days later, the patient returns for follow-up and says that her symptoms have improved. Labs show an anti-nuclear antibody that is negative, rheumatoid factor that's negative, and anti-CCP antibody that is negative. CRP is 50. X-rays of the hand show periarticular osteopenia and erosions of the proximal interphalangeal joints and metacarpophalangeal joints. Which of the following is the best next step in the management of this patient? Is it A, low-dose prednisone, B, methotrexate, C, infliximab, D, hydroxychloroquine, or E, continue ibuprofen only? Okay, let's move on to question 3. After obtaining appropriate labs prior to commencement of the new treatment, the benefits and risks are described to the patient who agrees to begin treatment. Which of the following additional steps is appropriate in the management of this patient? A, supplemental pyridoxine, B, supplemental folic acid, C, supplemental mesna, D, tuberculin skin testing, or E, interferon gamma release assay. Okay, we're going to go to question 1 and discuss this patient. So the answer is A, rheumatoid factor and naproxen. What does this patient most likely have? You can actually diagnose this patient clinically. This patient has rheumatoid arthritis. So whenever you're talking about a young woman with joint pain, rheumatoid arthritis needs to be on the top of your mind. You know, you got a lot of things that can cause joint pain. Rheumatoid arthritis, psoriatic arthritis, lupus, certainly parvo can do it too. More acute things like Lyme disease. However, what we need to consider, and you should always be considering when you're thinking about many things, but joint pain being a big one, is how long has this been going on? 2 months. 2 months of joint pain. That's a long time. Parvovirus certainly will not give you 2 months of joint pain. We also see that she has more general symptoms. Okay, she doesn't have a rash or a fever, but she's feeling sluggish. Okay, maybe we need to get a CBC. Maybe she's got anemia. Anemia of chronic disease would certainly be expected in something like RA or something like lupus. We would not expect to see it in something like Lyme disease or parvo. There's a family history of autoimmune disease. These autoimmune diseases tend to cluster in families, so that's kind of tipping you off to think of an autoimmune disorder. Now, on a test question, if they told you mom is 70 and has joint pain that gets worse as the day goes on, that's osteoarthritis. That is completely irrelevant when you're talking about an old family member. We also see that this is, again, inflammatory. Warmth, swelling, and tenderness of the proximal interphalangeal joints, metacarpophalangeal joints, and wrists bilaterally. What's the pertinent negative here? No distal interphalangeal involvement, and that is characteristic of rheumatoid arthritis. So now we're going to work on the assumption that she's got RA. So what do? Obviously not Lyme, not Parvo. Anti-dsDNA, what's that for? Lupus. We would expect to see a rash, oral ulcers, and stuff like that. Certainly, there's going to be rash. You would expect to see that lupus-like rash and that malar distribution. We don't see that here. That's typically going to be given to you on a test question. And then anti-CCP antibody titers and start sulfasalazine? No. Why not? Start with rheumatoid factor first, and then you can also, at the same time, get an anti-CCP, but you've got to get rheumatoid factor first. It's much more sensitive. Okay, anti-CCP is specific, but it is not as sensitive. Okay, and I believe CCP stands for cyclic citrullonated peptide. You don't need to memorize that. Okay, so you would start with rheumatoid factor. Anti-CCP is more specific, but you've got to get rheumatoid factor. Now, what else is wrong about this? Sulfasalazine. Sulfasalazine would be a good first drug to go to if you're dealing with mild inflammatory bowel disease, but it is not the first drug we go to when you're dealing with RA. So we get the rheumatoid factor, start naproxen. What is naproxen for? Naproxen's an NSAID, and this is a good drug to treat the flare, the symptoms, but it is not going to treat the underlying cause. We need a different drug for that. Okay. So now she comes back, and she's got a negative ANA, she's got a negative rheumatoid factor, and a negative anti-CCP. Does she still have RA? Yeah. Okay, 50% of patients will have this profile where they are seronegative for everything. Now, that doesn't mean they're always going to be like that. Like I said, half of patients at presentation are going to have negative ANA, rheumatoid factor, CCP. Okay, that does not exclude RA. So get that out of your mind right now if you're thinking that. Okay, you do not need to have these lab markers. These lab markers are good for confirming your presumptive diagnosis, your clinical diagnosis, but it is not by any means required. Okay, so we are still dealing with a patient with RA here. The CRP of 50, very elevated. That is indicative of an inflammatory process, most likely RA. If you were to get a SUD rate, same thing. And then the x-rays of the hands. Okay, you see joint destruction, you see bony destruction. Okay, this is, again, something that we see in RA. Because of its inflammatory nature, it can destroy the bone. Okay, so given the x-ray, the CRP findings, the clinical presentation, we can diagnose RA here, and there is actually a scoring system that you can use. You don't need to memorize it, but what I want to communicate to you is you can be negative for these lab markers and still have RA. Okay, so prednisone, this would be good for an acute flare, but what we're doing now is we want to treat the underlying condition. Her symptoms are better. The flare is over. Okay, now we need to treat the underlying cause. We need to treat the RA, not prednisone. Infliximab, can we use infliximab for RA? Yes, but it's second line because this is a more powerful drug. Hydroxychloroquine, how about that one? No. This wouldn't be first line in RA. This could be used in lupus. Continue ibuprofen only? No, we got to treat the underlying cause. Methotrexate is your initial drug of choice for active RA. Your initial drug of choice for active RA. Does that mean it works every time? No. Does that mean you may need to start infliximab down the road? Sure. But methotrexate is the initial drug of choice for active RA, and you have to know this. I have seen CCS questions where they expect you to know how to manage a patient who's coming in for the first time with RA, and they expect you to know that methotrexate is the drug that you need to send them home on once you have confirmed that diagnosis. Now, could we have gone back here and said, obtain rheumatoid factor and start naproxen and methotrexate? That could have been a right answer, and I'll show you why that is in a little bit. And then the answer to question 3 is simply to start folic acid. You've got a patient on methotrexate. What does methotrexate do? It inhibits dihydrofolate reductase, which is used in purine synthesis. Well, if you block purine synthesis, it's going to block cellular proliferation. That's a good thing when you're dealing with a lot of immune cells that are spitting out antibodies and other cytokines that's underlies these autoimmune conditions. So that's good. You want a little bit of immunosuppression when you're dealing with an autoimmune disease, but it can also reduce the cellular turnover of other cells, like in the oral mucosa, so you can get stomatitis. It can reduce the proliferation of cells in the intestine, so you can get diarrhea. It can have hepatotoxic effects as well. So folic acid is given to mitigate that, okay, to mitigate the myelosuppression, to mitigate the stomatitis, and it does a good job at that. Pyridoxine, when would we give pyridoxine to a patient who's on a drug? Isoniazid, used in TB, can cause neuropathy. What about Mesna? Cyclophosphamide, particularly high-dose cyclophosphamide that's used in chemo. Tuberculin skin testing and interferon gamma release assay, when would we order one of those? If we were to start anti-TNF therapy in this patient. So they failed methotrexate, maybe we tried a different DMARD, wasn't good enough, and now we need to do something a little bit stronger. We do one of those anti-TNF drugs. You always need to check for latent TB before you start an anti-TNF drug. So here's RA. I'm not going to run through all these, but what I want to point out, spares the DIP joints. That's a giveaway. Morning stiffness. Think of young women around 30 to 50 in that range. There can be cervical spine involvement, typically not on presentation though. Like I said, these markers, they're good to know. You got to know them, but they're not always positive. Look at rheumatoid factor, 70 to 80% sensitive, meaning 20 to 30% of patients aren't going to have a positive rheumatoid factor. Anti-CCP antibodies, very specific, but even less sensitive than rheumatoid factor. Really look at that CRP and or SED rate. That's going to give you a hint. That will always be elevated in RA, particularly during a flare. Get an x-ray. Again, you're just confirming your diagnosis here. On confirmation, start methotrexate. With folic acid supplementation, you can use NSAIDs for acute symptomatic relief. And as usual with most inflammatory diseases, you can use glucocorticoids for symptomatic relief during flares. Okay, so here's kind of how you're going to work at this. Rheumatoid arthritis, make the diagnosis, start methotrexate, treating the underlying condition. Make sure that you're using NSAIDs if they're having a flare. That's just to treat the symptoms. If they continue to have symptoms, swelling, and all that stuff, you can either do another DMARD, non-biologic DMARD like sulfasalazine or hydroxychloroquine. But the first one, always methotrexate. Or if that's not enough, you can go straight to the TNF drugs, okay? And make sure before you start to check for latent TB. Whether that's a Manto test or an IGRA, doesn't matter. You just have to check for latent TB before you start a TNF inhibitor. Now you can diagnose this clinically. Let's look at our patient here. She had multiple small joints that were involved. Probably more than 10, so we're going to say here that's 5 points. Serology was negative all throughout. That's 0. CRP SED rate, that was elevated, so that's 1. Duration of symptoms, what were we at here? 2 months. So certainly more than 6 weeks. So that's 1 point. Put it all together, that's 7. If it's more than 6, 6 or more, it's definite RA. Now rule out psoriatic arthritis. We would expect to see dactylitis. We would in many cases expect to see a rash, so that's out. Viral polyarthritis doesn't last this long, not inflammatory. Gout and CPPD doesn't have the risk factors, typically not several joints. Gout, it could be in the knee, could be the toe, but it's not going to happen in multiple joints. She doesn't have a lot of risk factors for gout. She's young. She's not on any kind of chemotherapy drugs, so that's out. CPPD, kind of same thing. And then lupus, less likely. She doesn't have the rash. She doesn't have aphthous ulcers. We're not expecting lupus here. Okay, so there you go. That's all right. Here's your DMARDs. Methotrexate is our first to go to an RA. We talked about the adverse effects. Leflunomide is another one you can go to. Pretty much the same adverse effects. Methotrexate's working with purines. Leflunomide's working with pyrimidines. Basically does the same thing. Hydroxychloroquine, think lupus. Do not give it for COVID. Our illustrious president does not seem to get the picture with that. Retinopathy is a big one with hydroxychloroquine. I had to tell tons of people, you take that horse dewormer, you're going to go blind. Okay, hydroxychloroquine, I guess that's not the horse dewormer, but, you got to tell them, right? So, hydroxychloroquine, though, does have ocular toxicity. Sulfasalazine, that's typically going to be your first drug to go to for IBD, mild IBD. Similar adverse effect profile. TNF drugs, big one here. Always check for latent TB. Okay, always, 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 always. Very important. Okay, question 4. A 24-year-old man presents to the clinic complaining of loose, foul-smelling stools for the past 3 months. He's tried adjusting his diet, but the problem has persisted, and he's concerned because since his symptoms started, he has lost 8 pounds. All right, he denies fever, rash, and swollen lymph nodes. He's sexually active with both men and women and uses condoms most of the time. He drinks heavily on the weekends but abstains during the week. He doesn't smoke and uses cannabis twice per month. Physical exam reveals mild abdominal distension with normal bowel sounds. Labs show an anti-tissue transglutaminase antibodies that are negative, fecal leukocytes negative, and stool PCR positive for Giardia duodenalis and non-typhoidal salmonella. Which of the following is the best next step in the management of this patient? A, HIV 1 and 2 antigen antibody immunoassay. B, 24-hour fecal fat measurement. C, ciprofloxacin. D, tinidazole. Or E, serum IgA level. Okay, so let's go ahead and answer this one. It's tinidazole. So what does this guy have? Okay, loose, foul-smelling stools, weight loss. Okay, I don't know why they say foul-smelling stools. I mean, I have never seen a stool that smells good, but when they say foul-smelling stools, what they're really getting at here, particularly if they don't tell you about weight loss, what they're getting at here is that there is fat in the stool. Okay, there's fat in the stool. And this is something that we see in malabsorptive diarrheas, celiac disease, cystic fibrosis, chronic pancreatitis. You would expect to see this, okay? So very important that you identify that. This is called steatorrhea, okay? Which basically means no fat absorption. And when you're not absorbing fat, you're not absorbing nutrients, you're not absorbing fat-soluble vitamins, so you can lose weight, you can have signs of vitamin deficiency. Now, he's also lost weight, okay, we expect that. He doesn't have fever, rash, swollen lymph nodes. He's sexually active with both men and women, so we might think maybe some STI going on here. But what we saw was the anti-TTG was negative, probably not celiac disease. Fecal leukocytes, negative, interesting. Stool PCR, Giardia, and non-typhoidal salmonella. Okay, so he's got diarrhea, and he's got these 2 pathogens. Now, let's think about non-typhoidal salmonella. Does that cause a steatorrhea, a malabsorptive diarrhea? No. Okay? That does not do it. This non-typhoidal salmonella, like any salmonella, is going to cause an inflammatory diarrhea. We would expect to see leukocytes in the stool, and we do not. Okay? So one of the things about these stool PCRs is that they don't do a very good job of distinguishing between a symptomatic infection, what's causing the problem, and asymptomatic carriage. You have it, but it's not causing any problems. Okay, so we're not looking at this non-typhoidal salmonella as being the problem here because it doesn't fit that picture. However, Giardia, what do we know about Giardia? What kind of diarrhea does that cause? a subacute to chronic malabsorptive diarrhea, and that's exactly what's going on here. Okay, they gave you the perfect picture here of a patient with giardiasis. The only thing they didn't tell you is the dead giveaway that they're a camper, which is such an obvious way of giving the question away. Furthermore, salmonella, if you were thinking that, salmonella tends to be self-limited. It doesn't last for much more than a week, okay? So that, once again, does not fit here. Okay, so we're talking about steatorrhea, malabsorptive diarrhea in an otherwise healthy patient. When it's subacute, not associated with anything in his diet, you got to be thinking of giardiasis. Get the stool PCR. It'll give you a really good idea of what's going on here. Do not bother with stool cultures. It doesn't really do much. HIV 1 and 2 antigen antibody immunoassay. If we thought this was acute HIV, now acute HIV can cause diarrhea. It certainly, he fits the profile of the kind of patient that would get it, not using condoms all the time, sexually active with men, but this has been going on way too long. If you get diarrhea during acute HIV infection, it's going to be gone within a week. Okay, this has been going on for 3 months. 24-hour fecal fat, well, we know it's going to be positive. It's not going to change our management. Cipro. So Cipro would be something that you would give if the patient was really, really, really sick and we thought this was salmonella, but it's not salmonella and he's also not very sick. So that's out. And then serum IgA level. Okay, so patients with low IgA or low immune globulins in general do have a higher risk of giardiasis. However, this is not something we're going to do now. We need to treat now. And if for whatever reason the drug doesn't treat it properly, or if he continues to get episodes of giardiasis with no apparent exposure, then we might work him up for an underlying immunodeficiency, but it is not what we start with. We've got to treat the condition. The answer is tinidazole. Now, you probably, if you're like me, who went to medical school years ago, you probably learned this. The treatment is metronidazole, and metronidazole is no longer preferred as the first line. We use tinidazole or nitazoxanide. If the patient is pregnant, paromomycin. And then, like I said, if it's refractory or recurrent, work them up for an immunodeficiency, get an immunoglobulin panel. Okay, here we're looking at things like common variable immunodeficiency, which tends to present later on in adulthood. IgA deficiency, the big one there that they often give you is an anaphylactic reaction immediately to blood products. Cystic fibrosis, generally apparent early on in childhood, and HIV, but generally here we're talking more advanced HIV. Okay, let's move on to question 5. We got a 60-year-old man presenting to the clinic for his annual physical. He says he's generally feeling good, but he has been urinating more than usual over the past several weeks. Past medical history is significant for type 2 diabetes mellitus, which was diagnosed 10 years ago, and obsessive compulsive disorder. Medications include metformin and paroxetine. Physical exam reveals moist mucous membranes and no pitting edema. Remainder of the exam is unremarkable. Labs are as shown. Which of the following is the best next step in the management of this patient? Okay, let's look at the labs. Okay, so pause it, take a good look here. Make sure you use your lab handouts. Okay. Is it A, 3% sodium chloride infusion? B, discontinue paroxetine? C, switch from paroxetine to lithium? D, add glipizide? Or E, restrict water intake? Okay, let's go to our answer. Restrict water intake. All right, so what does this guy have? Hyponatremia. Okay, now anytime you hear that somebody is peeing a lot, the very first thing you need to do is get electrolytes and a urinalysis, both of those. Now you can get these other things, that's good. In a diabetic patient, definitely get an A1C, but you need to get electrolytes and urinalysis because we want to know how much sodium is, how much sodium's in their body. That's important. But we also want to know what's their serum osmolality to their urine osmolality, because that's going to tell you something about fluid balance. Where is this fluid going? Is it going to the right places? So we know that this patient has moist mucous membranes and no pitting edema. What does that mean for his volume status? euvolemic. Okay, if he had dry mucous membranes, hypotensive, we would think that he was hypovolemic. If he had pitting edema, hypervolemic. So he's euvolemic, he's got hyponatremia. Euvolemic hyponatremia, when you're dealing with that, there's two big things that cause that. Primary polydipsia and SIADH. Okay? So, this is a patient who's got obsessive compulsive disorder. Okay? Got obsessive compulsive disorder. That's certainly a risk for primary polydipsia. However, he's on paroxetine, which is an SSRI, which we know is a risk factor for SIADH. What do we do? Well, look at your osmolalities. So his serum osmolality is 265. Is that low, normal, or high? Low. Now, if the serum osmolality is low, it's dilute, what would we expect the urine osmolality to be? Dilute or concentrated? Dilute. So that's the normal process. Okay, that doesn't mean it has to be like that. That's the normal process. Well, his serum osmolality is low, and his urine osmolality is low. Okay, so basically what this is telling you is that everything that's supposed to be going on is going on. So this is probably self-induced. It's probably primary polydipsia. SIADH, what would we expect there? Well, SIADH means that you have too much antidiuretic hormone, meaning that you are concentrating your urine too much. You're holding on to water. You're pulling water back in from the filtrate when you shouldn't be. So in that case, we would expect to see a high urine osmolality. Okay, so SIADH is a high urine osmolality, whereas primary polydipsia is an appropriately low urine osmolality, and that's how you tell the difference. So you got a patient who's hyponatremic, and they're euvolemic, their mucous membranes are moist, they're not edematous, then it's primary polydipsia versus SIADH. And in that case, it is your urine osmolality that will tell you what's going on, and because it's primary polydipsia, we restrict water intake. Okay, so 3% sodium chloride infusion, when would we do that? That would be if he was highly symptomatic. He had hyponatremia and he had severe symptoms like seizures or comatose. Well, he's not that. He's feeling good, so that's out. Paroxetine. He doesn't have SIADH. He's got primary polydipsia, so with no need to discontinue. Glipizide. So if he had uncontrolled diabetes, that could certainly cause the excess urination. However, he would be losing a lot of water. And typically what happens from that is they do become dehydrated. Furthermore, look at these labs. Hemoglobin A1C of 7.1, good control. Glucose, 110, good control. We don't need to give him any more diabetes drugs. Restrict water intake. So here is a chart that you can use. Again, you're dealing with euvolemic hyponatremia. All you really need to do is look at your urine osmolality. It's going to tell you the whole story. All right. Another good one here, the hypovolemic hyponatremia. Again here, because you're hypovolemic, what should your kidney be doing? It should be reabsorbing water. Well, whenever you're reabsorbing water, you're reabsorbing sodium. So if you're hypovolemic and you're reabsorbing sodium, that's exactly what you should be doing. Your urine sodium then is going to be low because you're reabsorbing sodium, you're reabsorbing water. That is non-renal salt loss. Nothing wrong with kidneys. Kidneys are doing exactly what they're supposed to be doing. If the urine sodium is high, what that's telling you is that the kidneys are not doing what they're supposed to be doing. You've got a low volume status, but you're not reabsorbing water, you're not reabsorbing sodium. That's telling you that the problem is the kidneys, either that's from a diuretic or from adrenal insufficiency. Okay, and then these other ones you can look at on your own. These two kind of blend together. So this is how I approach hyponatremia. If I see a low sodium level, first thing I look at is the serum osmolality. In many cases, it's going to be hypotonic. If it is hypotonic, next question is what's their volume status? You can typically figure this out on physical exam. If they're dry, low blood pressure, then what we begin thinking of is, okay, are the kidneys conserving sodium? Okay, are they appropriately reabsorbing sodium from the filtrate? If the answer is no, it's renal loss. If the answer is yes, it's non-renal loss. Okay, think of sweating. You're losing lots and lots of sodium in that sweat. What your kidneys should be doing is reabsorbing sodium from the nephron, from the filtrate. Okay, now if they're euvolemic, they've got moist mucous membranes, no edema, then it's SiADH versus polydipsia. And it's as simple as looking at the urine osmolality. If it's abnormally concentrated urine, you're reabsorbing way too much water, SiADH. If it's normal osmolality, low osmolality, which we would expect when a patient has low serum sodium, then it's primary polydipsia. Beer potomania is another one. Basically, what goes on here is that these patients drink a lot of alcohol, causes them to lose sodium in water, and they're replacing it with plain old water. So it's a net sodium out. Okay, question 6. A 66-year-old woman presents to the ED complaining of chest palpitations for the past 6 hours. She was diagnosed with paroxysmal atrial fibrillation 3 months ago. After thorough workup for underlying causes, including echo, EKG, and thyroid function tests, she was started on amiodarone. This resolved her symptoms until this episode. She has no other symptoms. Past medical history is significant for hypertension. She doesn't drink alcohol, smoke, or use recreational drugs. Medications include metoprolol, low-dose aspirin, and ginkgo biloba. Vitals show blood pressure 119/78, heart rate 115, respirations 12, temperature 98.6. Physical exam is unremarkable. CBC and BMP are within normal limits. Other labs, the TSH is 4.4. The T4, total T4 is 16.1. Total T3 is 72. Make sure you're using your lab handouts. Which of the following is the most likely underlying cause of this patient's abnormal thyroid function tests? A, euthyroid 6 syndrome. B, subclinical Graves' disease. C, adverse effect of metoprolol. D, adverse effect of ginkgo biloba. E, adverse effect of aspirin. Or F, adverse effect of amiodarone. Okay. So after that, the next question then is, which of the following is the best next step in the management of this patient? A, levothyroxine. B, prednisone. C, discontinue amiodarone and switch to another antiarrhythmic. D, recheck thyroid function tests next month. Or E, obtain TSH receptor stimulating antibodies. Okay, so we're going to go on to the answer to question 6 now. Here it is again. And the answer is F. Adverse effect of amiodarone. So what is going on with this patient? So the patient has chest palpitations. The patient also, looking at their thyroid panel, take a look at this. TSH of 4.4, is that normal, high, or low? Normal. Total T4, 16.1, normal, high, or low? High. And total T3, normal, high, or low? Low. Okay, that's an interesting profile. The TSH is normal, the T4 is high, and the T3 is low. Where do we see that? You see it in 2 conditions, but one big one. So you see it in euthyroid 6 syndrome sometimes, and you see it in amiodarone. Why amiodarone? So amiodarone does 2 things. It decreases thyroid hormone synthesis, and it decreases conversion of T4 to T3. That explains this. You've got a high T4 relative to T3. Now remember, euthyroid 6 syndrome does this too. Okay, it doesn't have anything really to do with thyroid hormone synthesis, but it does decrease the peripheral conversion of T4 to T3. So you can get a similar lab picture. But typically with euthyroid 6 syndrome, you may see some abnormalities of the TSH, you may not. But euthyroid 6 syndrome, what would we expect to see in this patient? Does this patient look like someone who's got euthyroid 6 syndrome? No. Euthyroid 6 syndrome, these patients are sick. Often they're in the ICU. They're on steroids. They're very, very, very sick. That doesn't make sense here. Subclinical Graves' disease, what would we expect to see there? T3 and T4 would be high. TSH would be low. So it's not that. It doesn't fit the lab picture. Adverse effect of metoprolol. Metoprolol is a beta blocker. Can beta blockers decrease peripheral conversion of T4 to T3? Yes. Can metoprolol do it? No. Metoprolol is cardioselective, just like atenolol. Propranolol could do it. Adverse effect of ginkgo biloba? No. No thyroid problems there. Dizziness, headache, constipation, can screw around with your warfarin levels, can raise it so you can get bleeding even if you don't change your warfarin dosage, but it's not going to do anything there. A lot of people take ginkgo biloba because they think it helps with memory health. So older people, they're on warfarin, you need to think of that. Adverse effect of aspirin? No. Gastritis, peptic ulcer disease, but not thyroid. So there you go. It's F. Now, the best next step in the management of this patient is going to be to recheck thyroid function tests next month. Why? Amiodarone-induced thyroid abnormalities, they tend to be worst in the first few months of amiodarone. Okay, that's roughly corresponds with its half-life. So the first few months of amiodarone, you're going to see abnormalities of the thyroid function tests. However, after that, it should improve. As long as the patient is clinically euthyroid, as long as they're not having, weight loss and sweating and all that stuff where it's unbearable, you can continue the amiodarone. All right. Now, this patient has some chest palpitations. It is up to her whether she wants to continue. She can continue the amiodarone. Okay, now if she was having thyroid storm, absolutely not. Okay, so levothyroxine, we don't need to do. Furthermore, she, if anything, is hyperthyroid, so that's out. Prednisone, we'll talk about when we use that, but we don't use it here. Discontinue amiodarone and switch to another antiarrhythmic. We don't have to. We already talked about that. Obtain TRABs? No. No. Okay, Graves' disease looks completely different. Graves' disease would give you a goiter. Graves' disease tends to present younger. This woman's in her 60s. Graves' disease tends to present women in their 30s, 40s, and 50s, so that doesn't make any sense. Okay, so here are the effects that amiodarone can have. We talked about decreased T4 to T3 conversion. That is what is happening here. Okay, TSH was normal, T4 is high, T3 is low. Okay, treatment, observation. That's what we're doing here. Inhibition of thyroid hormone synthesis. That can definitely also happen from amiodarone. The degree is questionable. We would expect to see a high TSH and a low T4. Low T4. Okay, we don't see that here. We see a high T4, so that's out. But if she were hypothyroid, levothyroxine can be given during amiodarone therapy. Amiodarone-induced thyrotoxicosis. Okay, so what would that look like? It would look like hyperthyroidism. You do the radioactive iodine uptake scan, as you should in a patient with hyperthyroidism. When you're trying to differentiate them, you'd expect to see decreased uptake. What is that? When you have hyperthyroidism and decreased uptake, that's a thyroiditis picture. Okay, and we do the exact same thing. Antithyroid drugs, you'll know based on the history of amiodarone. By the way, amiodarone, why does it screw around with the thyroid? Look at the name. IOD. Iodine. It's got iodine in it, so it can screw around with your thyroid. Okay, amiodarone-induced thyrotoxicosis type 2. So this is... what's happening here is, again, it's like a thyroiditis. Okay, in this case, you use glucocorticoids because this is generally more severe. Okay, so you use glucocorticoids here. This is fairly low yield for your exam, but you should understand how amiodarone works. Decreased peripheral conversion, inhibits thyroid hormone synthesis. Usually it's going to either cause a hypothyroid picture, which is going to look just like primary hypothyroidism. It's going to look a lot like Hashimoto's. Decreased T4 to T3 conversion, that's very common. It's typically not a problem. Big thing here, differentiate this from euthyroid 6 syndrome. Very easy to do. Just look at the clinical picture. If you've got a patient on amiodarone who's hyperthyroid, then you need to think of one of these thyrotoxicoses. I don't think you'll be asked upon that, just simply because the differential is really hard to do. But just like in any hyperthyroidism, you think about antithyroid drugs and steroids. Okay, so we got a 55-year-old woman who is recently diagnosed with HER2 positive, estrogen receptor positive, progesterone receptor positive, stage 1 breast cancer. 3 weeks after diagnosis, she underwent breast conserving surgery. A 1.5 centimeter diameter tumor was removed with negative margins. Sentinel lymph node biopsy was negative. Following surgery, she began therapy with letrozole, paclitaxel, and trastuzumab. 2 months after beginning this treatment, she complains of dyspnea on exertion. Echocardiogram is performed and reveals an ejection fraction of 32% compared to 60% prior to starting treatment. When the patient asks about her treatment regimen and prognosis, which of the following is the most appropriate response? A. Complete recovery of your cardiac function is expected after discontinuation of trastuzumab. B. Partial recovery of your cardiac function is expected after discontinuation of trastuzumab. C. Recovery of your cardiac function depends on how long you were on trastuzumab. D. We should not make any changes to your current chemotherapy regimen. E. It is likely that you had underlying coronary artery disease prior to starting trastuzumab. Or F. Trastuzumab did not play any role in your exertional dyspnea. Okay, this is a tough one here. It requires you to know about adverse effects. So the answer is A. Complete recovery of your cardiac function is expected after discontinuation of trastuzumab. What is trastuzumab? Trastuzumab is a monoclonal antibody targeting human epithelial growth factor receptor 2. So in HER2 positive breast cancer, we always give trastuzumab or another drug of its class that is a monoclonal antibody against HER2. Okay? Always, always, always. Now, in this patient, why did she have to go on paclitaxel? Why is she on chemotherapy if she is stage 1? Why don't we just do breast conserving surgery, radiation, and be done, or maybe give trastuzumab because she's HER2 positive? Why are we doing chemo? Typically, we do chemo at stage 2, 3, and 4. HER2 positive breast cancer, chemo no matter what. Okay? Chemo no matter what, unless they, decide they don't want it. But we're going to put her on Taxol. Okay? Stage 1 breast cancer, if it's HER2 positive, we do chemo. Not just the trastuzumab, but actual cytotoxic chemo. All right, so trastuzumab, what you need to know is that it is cardiotoxic, okay? Cardiotoxic. However, it is reversible, okay? So trastuzumab is cardiotoxic and reversible. Now, why do I stress that it's reversible here? Are there any other drugs we give for cancer that cause cardiotoxicity? Yes. What class? Anthracyclines. What's an example of an anthracycline drug? Doxorubicin. Okay. Now, if you are exposed to doxorubicin or another anthracycline, that can cause dilated cardiomyopathy. That would cause a reduced ejection fraction. However, that is not reversible. Okay, so you go on doxorubicin, you get dilated cardiomyopathy. That's not reversible. Okay, it does not go away upon discontinuation of the drug. As a matter of fact, if you're on doxorubicin, you may not have any adverse effects of that. You may not have any reduced ejection fraction. It may occur 10 years down the road. Okay, so it has to do with how long and how much you were exposed to. With trastuzumab, it doesn't. You're only going to have problems while you are on it. After discontinuation, it will get better. And as a matter of fact, it will get better completely. You should go back to normal. So that eliminates B, and that eliminates C. C applies to the anthracyclines. We should not make any changes to your current chemo regimen. You actually have to. So if you have more than 15% reduction from baseline, which we see here, a 28% reduction, you need to stop trastuzumab for 4 weeks before starting it back up again. And that's just a testimony to how reversible this is. Likely coronary artery disease? No, that has nothing to do with this. And didn't play a role? No, of course it does. So it's A. All right. This is me and my mom. My mom was diagnosed with HER2-positive stage 1 breast cancer in 2021. Absolutely horrifying thing to go through. The problem for her is that it was such a small tumor. And I told her, don't worry, you're probably just going to need to have it taken out and you'll have to go to radiation. Comes back HER2 positive. Now she's got to go through chemo. You can see her hair is just starting to grow back here. But it was a stage 1 cancer, one of the rare times with a stage 1 cancer where you'll have to go through chemotherapy. Of course, she had to also go on trastuzumab. She had to take letrozole afterwards, and also bisphosphonate. So she's had the works done, but fortunately, stage 1, 99 to 100% 5-year survival rate. So I expect her to be nagging me for many, many more years. All right, question 9. A 70-year-old woman presents to the ED with her husband complaining of loss of consciousness. She was sitting on her couch knitting while her husband was watching TV, and she suddenly passed out and slumped over the side of her couch. Within 20 seconds, she recovered consciousness completely. She says that she's had some pain while urinating for the past few days, but has not been seen for it. She's had a loss of appetite and thirst since the urinary symptoms started. She's generally healthy and has no significant past medical history. Medications include low-dose aspirin. Vitals show blood pressure 101/62, heart rate 35. Respirations 12, temperature 99.4. Physical exam is notable for mid-lower abdominal pain to palpation, abdomen soft and non-distended. Mucous membranes are dry. Labs and EKG are as shown. Which of the following is the best next step in the management of this patient? All right, let's look at our labs and EKG, and we'll come back. So here's our labs. And here's our EKG. Okay, let's go ahead and look at our answer choices. A, start dialysis. B, IV dextrose and insulin. C, IV calcium gluconate. D, Kayexalate. Or E, transvenous pacemaker. Okay, here's your labs. Here's your EKG. Let's go on to the answer. Calcium gluconate. What's going on with this patient? So she's been sick, all right? She's had some pain urinating, hasn't been seen for it, and because of the pain while she's been urinating, she's also not been eating and drinking very much. So that's not helping. But, okay, maybe that explains the low blood pressure, but why a heart rate of 35? That doesn't make any sense. We better be getting an EKG. We're thinking maybe heart block, some kind of an arrhythmia. We need to figure out why. So yes, we're going to get the labs, but we need to get this EKG. And let's just look at this EKG. What do we see here? Bradycardia. Is this sinus bradycardia? No. What do we see? What do we don't see? No P waves. No P waves anywhere. P waves are nowhere to be found. What else do we see? Peak T waves. What does this patient have? Hyperkalemia. Very simple. Okay, it's the only place you're going to see that. You also see some ST depression. Where's the ST depression? Yeah, so ST depression there. Very typical signs of a moderate hyperkalemia. Look at the labs. Hyperkalemia. So a little bit of a hypernatremia. Bicarb is low. BUN creatinine, 75 to 2.5. Ratio of 30. What's causing this acute renal failure? Hypovolemia. Okay, this is a pre-renal failure, definitely reversible. But she's got hyperkalemia. That's due to the pre-renal failure, probably been going on for some time. Okay, so hyperkalemia. How do we treat hyperkalemia in a patient who's got symptoms? Okay, so she's got a bradycardia due to the hyperkalemia. We need to treat the cardiac problem first. We do that with IV gluconate. Then we will go on and treat the hyperkalemia. But the biggest complication of hyperkalemia is cardiac arrhythmia. We got to treat the cardiac arrhythmia first, and then we will treat the hyperkalemia. All of these things, dialysis, dextrose insulin, Kayexalate, they're all good at treating hyperkalemia, but they're not going to treat the underlying cause. And this woman could go into VFib or going to asystole very, very quickly. So we need to get IV calcium gluconate on board. Then we can start considering these other things. Dialysis, dextrose insulin, Kayexalate, those are all fine. But you've got to do calcium gluconate first. Transvenous pacemaker, no, overkill. We can treat this with calcium gluconate, reverse the hyperkalemia, and we're good to go. So there you go. Okay, we'll finish off with question 10. A 50-year-old man presents to the clinic for follow-up on his hypertension. He was recently seen in the ED for what was diagnosed as lumbosacral strain. His blood pressure at that visit was persistently around 150 over 100 even after the pain was relieved. At a follow-up visit 2 weeks ago, his blood pressure was 140 over 95. He's never been treated for hypertension before. He's got a past medical history of bipolar 1 disorder, which has been well controlled on lithium for the past 5 years. He has no other medical conditions and is on no other medications. Vitals show blood pressure 142 over 95, heart rate 88, respirations 12, temperature 98.6, BMI is 28. Physical exam is unremarkable. CBC, BMP, and urinalysis are all within normal limits. Lithium level is within the therapeutic range. After discussing treatment options with the patient and his attending psychiatrist, it is decided that an antihypertensive drug will be started, but the patient should be continued on the same lithium dosage if possible. Which of the following agents would be most appropriate for this patient? A. Hydrochlorothiazide, B. Lisinopril, C. Amlodipine, or D. Valsartan? Okay, this is a straightforward one. Difficult, but straightforward. Amlodipine. Okay, there are two antihypertensive drugs that will not screw up your lithium levels. What are they? Calcium channel blockers and loop diuretics. Okay, these are the only two that will do it. ACE inhibitors, ARBs, they're going to, I suppose you might be able to include beta blockers in here, but that's questionable. Okay, some believe there may be an effect, but we'll just leave it at calcium channel blockers and loop diuretics. If beta blocker comes up, I would err towards safe, but these two are the ones that are definitely deemed good for lithium. So hydrochlorothiazide, what kind of drug is that? Thiazide diuretic. Thiazide diuretics will tend to raise your lithium level. Lisinopril, what kind of drug is that? ACE inhibitor. ACE inhibitors and angiotensin receptor blockers tend to raise your lithium level. There's really no drugs we give for hypertension that are going to lower your insulin level, or sorry, lower your lithium level. So you can see here, osmotic diuretics, mannitol, we really never give that. I mean, you give that, I suppose, in, cerebral hypertension or something like that, a brain injury, but in that case, you got bigger fish to fry than your lithium levels. Theophylline, used to give it in asthma, really not given too much anymore. Minimal effect, loop diuretics, calcium channel blockers. Beta blockers would probably be okay, but questionable. Increased lithium levels, we talked about all those. ACE inhibitors, angiotensin receptor blockers, hydrochlorothiazide, some other ones, NSAIDs, and certain antibiotics can do it too. But if they're going to give you a question on lithium levels, it's probably going to be one of these. ACE inhibitors, ARBs, thiazide diuretics can all do it. Loop diuretics, calcium channel blockers, much safer when we're talking about keeping lithium levels within a therapeutic range.